Hello, everyone. Thank you for joining us today in our first panel or second in the topic of global surgery, the first in the National Surgical Obstetric and Anesthesia Plans. Today, we are lucky enough to have four panelists, and the fourth one he will be joining us soon, and we will kick start by the three of us, Irene, Elena, and Shahid. Can you please start by introducing yourself, telling us a bit about yourself, and then we will keep the ball running after that. Start by Irene, please.
Thank you so much for the opportunity, Mohammed. So my name is Irene Divine Girassa, and I work at Operation Smile. Operation Smile is an international NGO which does free cleft surgeries for people all over the world. But we are also engaged in working with governments and ministries of health to develop policies which aims at improving systems to deliver effective and safe surgical care all over the world. So at Operation Smile, I lead our health policy and advocacy efforts in Africa. And I'm very excited to be part of this meeting tonight.
Thank you, Irene. Thank you very much. And Irene as well, she's doing a huge job with the global surgery era, and she's part of the G4 Alliance and a lot of other organizations. Okay. Up to you there, Irene. Elena, please go ahead and start introducing yourself and let us know who you are.
So my name is Elena Datey. I'm a medical doctor based in London. My clinical experience spans neurology, acute medicine, orthopedics, internal medicine, and I've worked in different hospitals in London, such as the Royal National Orthopedic, Royal Free, and UCLH. So I also have a master's in global health from King's College London. There I contributed to research on assessing the fracture care system, the fracture care needs in DRC, Democratic Republic of Congo. So that was a head-to-toe evaluation of that healthcare system in Congo Central, and this was done in partnership with their Ministry of Health as well. So my interests kind of lie in surgery, surgical system strengthening, and policy and advocacy, with the aim to address systemic barriers, especially in low resource settings. So I'm excited to be part of this panel discussion and expanding surgical care in Sudan.
Great. Thank you very much. Thank you for this amazing introduction. We'll go to Shahid. Please go ahead.
Hello.
Shahid.
Hello, everyone. It's a pleasure to be with you and to join you today. My name is Shahid Nasruddin Abdel Habib. I'm a graduate of Nilan University in Sudan, where I did my foundation. And after that, I moved to London to do a master's degrees in global health policy at LSE. During my time at LSE, I worked as research assistant at the Global Surgical Unit, studying the cost effectiveness of surgical interventions in the LMICs. And I worked as part of my dissertation regarding studying the national surgical anesthesia plans. Currently, I'm working as clinical instructor at SGU and serving as the co-chair of the conflict and disasters as part of the G4 Alliance as well.
Perfect. Shahid, you started talking to us like with the policy language from the beginning. So my question to you is, tell us what is LSE in words and what is LMIC in words.
Okay, so LSE is the London School of Economics and Political Science. It's one of the universities in the United Kingdom that is focused in the policies and the economics. And there is a part of for the health, of course, which they have the unit of the health policies that have different master's programs. And LMICs is the low and middle economic income countries. So it's just as an abbreviation that used to say when you are dealing with these fields.
Yes, great. So because we need all of us to be on the same page to to be with you and to understand everything you are saying. And I'm happy that we have been joined by Professor Shadul. He's the executive general director of the Sudan Medical Specialization Board. Your insight will be very helpful in the discussion up front. And so we will continue because we have a very limited time. We'll try to cover as much as possible, to learn as much as possible about the topic. Now we'll go back to you, Irene, again. And in 2 sentences, please tell us what NSOAP mean and why NSOAP is important.
Very well. Thanks very much. So NSOAP is basically an abbreviation for National Surgical Obstetric and Anesthesia Plan. And this is more or less like a policy or a document or a blueprint which countries develop, stating clearly for a particular number of years what investments they want to make into their surgical systems to be able to deliver safe, affordable surgical care to their people. It includes all the activities that they need to carry out, from human resource, service delivery, governance, infrastructure, with the indicators they want to improve, the timelines, and then the budgets that they want to use to address these things. So basically, that is what NSOAP means. In other countries, you find them adding NSOTA T to it, which means trauma. So National Surgical Obstetric Trauma and Anesthesia Plan, but all of them seek to address the gaps in surgical care in the countries where they are developed.
Perfect. That's really nice. Then we go to Elena. Please share with us your thoughts on what's the NSOAP and why it is important. You are on mute, I'm sorry.
Sorry.
Yeah.
So I think Irene gave a very good summary. So I think the overall surgical system strengthening, which NSOAP contributes to, has historically been a neglected part of global health investment. And so it takes a lot of effort to overcome many years of under prioritization. And as we know, equitable access to safe and timely surgical care is a fundamental human right. And it's a shame that still roughly 2/3 of the world's population still doesn't have this safe, affordable, and timely access to surgical and anesthetic care. And this includes surgeries such as cesarean sections and fracture repairs. So this line of work, pursuing this line of work, we can ultimately reduce preventable deaths and disabilities, especially in these low resource settings.
Great. Thank you very much. And Shahid, can you please elaborate more on what is NSOAP, and if you remember the hierarchy of the NSOAP or the pillars of the NSOAP as well, just shed them out there so we know. You are on mute as well.
Sorry for that. So NSOAP as a definition has been covered mostly. Thank you for our two panelists. But there is one of the perspective that I really love to look at the NSOAPs from that perspective is as someone who is interested in financing and health economics, as it's made for reducing the unnecessary cost or wasted cost of hospitals and the LMICs, the low and middle income countries, because they need that much of money to make use of it in other areas, to provide or to contribute to achieving the universal health coverage, particularly in these underserved regions like Sudan. And I love to think of the NSOAP as the ultimate financial diet plan for countries or hospitals. They trim the fat of wasteful spending, like keep surgeons from ordering unnecessary surgical snacks, ensure every penny is spent saving lives effectively, and it's like giving hospitals money, saving superpower while still being the hero that patients need or for the health systems.
Yeah, I hate that, but you mentioned it in a quite good way, so I can't disagree with you. So perfect. Question to you, Irene. As someone who's part of Ghana National Surgical Plans, and my question is, what would you do different if you were to plan it again?
Thanks for the question. And what would I do differently? I'll quickly pick it from where Dr. Al-Shahid ended, especially because he mentioned issues about funding. For most national surgical plans which were developed, implementation became a problem. There are examples from Tanzania, Rwanda, and other African countries, and all because the issue about funding was not addressed right from the start of the development of these policies. So if there was something that I was going to do differently, I'll make sure that right from the development of the policy, there are plans for implementation. And if there are plans for implementation, then resource mobilization and people who will contribute to these resources will be included in the development of the entire strategy. So I would have recommended that we have people from the Ministry of Finance to be part of the development of the NSOAP and all other development partners like unfortunately USAID has pulled it up. So maybe the UK High Commission, the GIZ, maybe from Canada, whatever government officials are in the country and are investing in healthcare would have been part of the development so that right from there, people know which aspects they would have to fund, because funding and resource mobilization has been the key reasons why most NSOAPs that were developed have not been implemented to the extent that they had to be implemented.
Great. I'm sure Shahid as well will be happy to discuss the financing in down the stream there, because he has done a study evaluating the NSOPs as well, and that's a very nice point from you, Irene. Thank you for that. I will go to Elena for a question regarding the assessment of surgical system. How do you think the assessment of surgical system is important? And how can we integrate the NSOAP with the existing health system to improve the surgical care?
Okay, so countries generally use baseline assessments and surveys to gauge surgical capacity. These include nationwide surgical audits, modified tools to provide information on like the infrastructure, the workforce, and the service readiness, and that's kind of the work I was doing in DRC. To kind of effectively assess these surgical systems, it involves evaluating certain metrics. The most widely used metrics at the moment are indicators defined by the Lancet Commission on Global Surgery. So they include perioperative mortality rates, surgical volume, specialist surgical workforce density, expenditure, and the so-called social economic status of people. Challenges in low middle income countries in particular do include the scarcity of data, as well as the limited funding, and of course workforce shortages. So new approaches like rapid assessments and like local capacity building is extremely important.
Okay.
Yeah.
Sorry to interrupt you, but is there like in these tools or these pillars that you mentioned, there is specific tools are very well accredited by the Lancet that could be used, or it is something that we need to design from the beginning? Like, for example, the capacity, the surgical volume, the mortality, there is a specific tools already there?
Yep, so there are a number of different tools. So, for example, what I use for the fracture care system, I kind of used like a combination of tools that were available. Again, it depends what you're evaluating.
Yeah.
So certain conditions might be better suited to certain tools when looking at specific conditions within surgery. And then again, you have to pick a tool that is best suited to the country, the region that you're doing it in. So like contextualizing the tools. For example, for my study in Congo Central, in fracture care, I kind of merged the IOM metrics of quality of care, and I used the WHO healthcare building blocks as well. And I kind of use those tools essentially help you formulate like surveys or like just ways to collect data in a way that when you collect this data, you can compare it to other people's studies or similar studies in other countries. And that can kind of, set the baseline, and then other stakeholders can now see where the gaps lie and where maybe funding needs to go into, or where more data needs to be collected, or like where a country is struggling in, if that makes sense.
Great. Yeah, that's really a very comprehensive answer. Thank you. We have been joined by Enoch, our fourth panelist. Thank you, Enoch, for joining. Can you please introduce yourself, and then we will direct the upcoming question to you. Thank you, Enoch. You are on mute. Enoch, sorry, you are on mute if you are speaking. Enoch, can you hear us?
Yes, I can hear. Can you hear me?
Yes, go ahead, please.
Perfect. Thank you. And I'm sorry, I wanted to apologize for my late attendance. But yeah, thank you for waiting for me. So my name is Enoch Kwacha. I am a doctor, and currently I'm a researcher with here with SCD and with OHMO. I'm doing my global health fellowship with OHMO, where I'm helping with publishing papers, and I'm also waiting on my licensing here in the UK. So yeah, and in my studies, in my master's program, that's where I met Mohammed, and I've known Elina since our first year in medical school. And also our Shahid, I've met him through Mohammed. So yeah, those are my colleagues, and I don't know if I missed any parts about myself, but yeah.
Perfect. You asked a lot, but we'll try to direct something back to you. So from your understanding of the surgical care service, based on the scoping reviews and the research that you have done in the global surgery area, and please tell us about the important findings that you find in assessing the surgical service in the LMICs or low middle income countries, and how could the NSOAP address these issues?
Okay, thank you for the question. So the thing is, from what from my research and what I have noticed, especially for the NSOPs, is most success NSOPs are quite recent. They are not in LMICs as much as we have countries that have adopted them, but most of it, I think the oldest is in Zambia from 2017. And then in 2018, that's when we had Rwanda, Ethiopia, and all the other countries trying to adopt. But the challenges that I have noticed that these countries seem to have, most of all, is like my colleague was saying, I don't know if I just heard it through the conversation, but as Elena was saying, was to do with the building blocks. So to build NSOPs, we have to start with things like financing. We have to talk about things like politics. We have to talk about healthcare training of professionals. We also need to talk about workforce. So all those gaps is I mean, umbrella wise, that's what all NSOPs, that's how they are built using. But also specifically to the context of LMICs, because for developed countries, they do have NSOPs, but most of them, they run parallel to their national or universal healthcare services. Like here in the UK, they have their their version of surgical plan is bind to the umbrella NHS healthcare plan. So it's not separate. But for us in LMICs, I'm sorry, maybe I'll be using language that is not as great, but for us in LMICs, we have this problem where because we don't have universal health coverage, we don't have a healthcare plan that umbrellas everything. We tend to have it in separate conditions. So for NSOPs, you have surgery, obstetrics, anesthesiology, whilst in other fields, you might also have other different plans. So, and because of this, we tend to have competition in things like financing. So ministries can allocate finance or money to a specific field, but because we are all competing for the same small amount of money, we end up having this problem. That's one major problem I've noticed with NSOPs. The adaptation with the rest is that competition of the little money that we have. So prioritization, we have to prioritize what are we going to use that small amount of money that we have? Are we going to put it on NSOPs? Are we going to put it on infectious diseases? Are we going to put it on non-communicable diseases? What exactly is that money is going to be used to? So yeah, I could speak for ages, so please stop me anytime.
Okay.
But
yeah, thank you, Enoch, for this dive in through the analysis and assessment of the LMICs through your view. So back to you, Shahid, as a Sudanese, that you know the context of Sudan, and as someone who's health policy and financing expert, my question is how we can develop a data context informed policy.
Thank you for this important question, Mohammed. As in the start of this discussion, you've talked about, or you mentioned, the 6 pillars of the NSOAPs. We've already covered 4 of them, and the last 2 is the governance and leadership and the information management for those. So when we talk about policy, especially in the context of surgical care, we must remember that good policies are not created in isolation. They are built on evidence, tailored to local realities and shaped by the people they serve. So to develop a truly data and context-informed policy for the NSOAP's adoption in Sudan, we need to highlight like 5 key areas that I think that they are important for that. So the first one is the strengthening of data collection and health information systems. We must build the strong foundation of data because without data, we are making decisions in the dark. We need a national surgical database to track surgical volume access and the outcomes. And we need to integrate surgical, obstetric, and the anesthesia data into our health management our health management systems. And importantly, we must ensure that our data collection is standardized and accessible so that it truly informs the decision making. And this will help us to identify where the gaps are and where people are suffering because they cannot access safe surgery. The second thing is using the context-specific research evidence. So we must ensure that the policies we develop are based on local realities. We can't just simply copy and paste solutions from other countries. We need to conduct national surgical needs assessment to understand where the biggest challenges lie. We need economic studies to determine which interventions are most cost-effective in Sudan's context. And we must use research to guide our decision making because policy without evidence is just a guess. Thirdly, we need to engage the stakeholders across the sectors. So policy is not just about writing documents, it's about people. If we want surgeons or if we want the NSOAPs to succeed, We need everyone at the table, the government officials, the surgeons, anesthetists, midwives, hospital administrators, and most importantly, the communities affected by limited surgical access. And we need to listen to their experiences, make sure that the policy reflect their realities, and we must engage the international organizations as well, like the WHO, the G4 Alliance, Operation Smile, for the technical support while ensuring that solutions remain Sudan-led and Sudan-driven as well. Also, to developing data-driven adaptive policies, policy must be dynamic. It's not static. What works today might not work 5 years from now. That's why we need a strong monitoring and evaluation system to track the progress and to identify the barriers and adjust the policies accordingly. This means like setting clear targets for surgical access, patient outcomes, and the infrastructure development. It also means making sure that the policies are equitable, that we prioritize rural areas, conflict-affected regions, especially in the current situation in Sudan, and the vulnerable populations who need surgical care the most. And finally, advocacy and capacity building and sustainable financing. So none of these or none of this will be possible without strong advocacy and sustainable financing. We must train policy leaders and decision makers on the economic and social benefits of investing in surgery. And we need to develop targeted policy briefs that present the data in a way that like convince the governments and donors to invest. And we must explore the innovation financing modules and public-private partnerships. And also, in addition to that, the regional collaborations and the external funding to ensure that the NSOAPs are not just policies on paper, but realities that transform lives. So if we commit to this, I believe we can make surgical care in Sudan like more accessible and equitable and life-saving as well.
Great. That's a really extensive and comprehensive answer, and it is very like detailed in a bit of that's why I'm tempted to ask the policy questions at the end, but thank you very much to this great answer. So I'm back to you, Irene. So as Shahid mentioned that the advocacy is needed and everything. So my question is, how did advocacy contribute to the success of your previous experience, to the success of Ghana's National Surgical Plan? And what strategy would you recommend for a country like Sudan?
So I would say that advocacy was the key machinery, because one thing that we have all observed is, for instance, one of the key mechanisms is the use of media. Most of the times, the media set the pace for issues that are discussed in the country. And once the media sets that pace, the discussions go around that. So there is a practice in Ghana where every morning on all the national television stations, they discuss and do something like a newspaper review, talk about the key issues that are being discussed in the newspapers. So one of the things we did was to write opinion pieces in the local newspapers. So we do a lot of research, we do analysis, we publish them in all the journals, but some of these journals never get read by the real policymakers on the ground. So one of the key aspects is writing in the local journal. So at a point, there was one that I wrote. It came after the Minister of Health at the time had come to speak about increasing maternal mortality in the country. So I went ahead and wrote an opinion piece on how strengthening surgical systems can actually help reduce maternal mortality. And that was on a local newspaper, which is widely read. So it got attention of media houses, where I was even invited to have discussions on a television station. Phone lines were open and people from the community called. And at the point, they expressed their interest even about some of their fears in terms of accessing surgical care in Ghana, which helped us to address some of these fears. Another thing is also policy analysis, key policy analysis, which other policies are in Ghana, because definitely there is some form of surgical care going on in Sudan at the moment. Some hospitals have protocols. So an analysis on what currently exists, even if it has not been published or accepted nationally, some hospitals are using some policies. So can we go ahead and now analyze these policies and see where we can align? So in Ghana, for instance, some of the policy analysis we did, clearly surgical care in some situations were not mentioned. So that became like a point where we used for our advocacy. So one thing I'll also recommend for the team in South Sudan is an evidence-based advocacy. The kind of advocacy we are doing should be evidence-based. And another key thing we did was inclusive participation. When we started at first, because at the technical working group, in fact, you see Operation Smart had worked with the Ghana Ministry of Health, but when you go to Ghana, ownership of the entire process was at the Ministry of Health. In any situation, I would recommend that the team from Sudan who are interested drives the process, but allow the Ministry of Health or whatever you call that body in Sudan to be the owner. They should take ownership and they should lead for sustainability, for continuity, for monitoring and evaluation. So the Ministry of Health owned the process, and so there was inclusion. The ministry wrote letters to the Nurses and Midwives Council. They wrote to College of Pharmaceuticals, Ghana College of Surgeons, and all these people brought representatives on board. So there was high representation. You don't want a policy that when you finish developing the policy, you know how health workers can sometimes go on strike and speak about issues. The nurses will come and say, oh, we were not involved, but we are supposed to implement this aspect. So
Yes.
Inclusive participation also played a very key role. Coming from the NGO point of view, there was a point some of the ministry people were very excited because they said that when they enter into a room and we are having a meeting, they are unable to differentiate between who is an NGO, who is a ministry because of the way in which I collaborated with them. So there was something that Dr. Al-Shaid mentioned that has to do with a Sudanese-led solution. So I was not imposing anything, even though I had experience from helping review Rwandan NSOAP. I know what went on in Tanzania based on Mohammed, the discussions we have at the G4 and all that, but it was led by the Ghanaian team. And so if you look at the Ghana Technical Working Group, it is a purely Ghanaian team.
Yes.
A purely Ghanaian team who developed this process. There were a lot of challenges. It was not an entire process without challenge. At a point, the issue about data ownership became a problem because at a point we felt that it's a process. It took us about 2 years actually. At a point, from an NGO point of view, we felt like we've put in so much technical energy and some finance, and the ministry was not driving the process. We were like, we've done a baseline data collection. Give us the data because we can close our eye and open and get someone to analyze the data. And then the issue came up with the ministry saying, okay, who owns the data? You supported us to collect the data, but the data is for us and we can't give it to you.
Yes.
So if I am making recommendations for people who want to go into these areas, we have to be clear on what our roles are. We don't need to overstep. We need to let the ministry take charge. If it will not be a bother, let me quickly share this. Do you see my slides?
Yes.
This is not a perfect process of NSOAP development, but we tried to map out every step that we put into it.
Oh,
if you look on this, you will realize that July 2024 is when we thought about consultant hiring. If you ask me today, I would recommend to the Sudanese team to look into bringing on board a consultant right from the start. Because what happened was that the NSOAP Technical Working Group were made up of technical people, surgeons, maxillofacial, pediatric anesthesiologists, specialist nurses. We go into a 3-day session. We set priorities. We know what to do. But when we leave there, these people, most of them go back to the theater. They go back to the hospital. And then who to write everything that was discussed becomes a problem. It started falling on me. And so we realized that we needed a consultant. So we brought on board a consultant who is a doctor and a public health person as well from the University of Ghana, who is very experienced. The Ministry of Health led in hiring him because they realized that he has worked on some policy documents which were very useful. And so this is not a perfect process for NSOAP, But you realize that at a point, we sent it to around August 2024, towards the end, to be reviewed by the Ministry of Health Plan Policy Monitoring and Evaluation.
Yes.
And as my panelists mentioned about monitoring and evaluation. And so this was reviewed by that department. At a point, we did a CPD course on it because we realized that when you talk about NSOAP, people on the ground did not know what it was about. And so while we do the high-level advocacy, I will also recommend grassroots advocacy so that people understand what is being developed. I think I'm going to pause here, but I said, this is not a perfect example, but you can see from where we have the red. The Ministry of Health started, they came up with a technical working group. COVID came in. They did not have funding. Activities stopped. And then in November 2022, Operation Smile joined. And from there, I tried to map up everything we did, from training of data collectors, drafting of the process, meeting with key people until the NSOAP was launched. At least it gives us an idea when we go into another country. We know what errors we made, we know which processes we want to come first, and we know which ones we need to be doing concurrently. I'm going to pause here for other speakers to take up.
Thank you very much. That is a very, very helpful answer. And you mentioned that the advocacy for the stakeholder, involving the key stakeholder, ownership, and the grassroots. By grassroots, what do you mean?
So by grassroots, I mean people who are really into the job of delivering the care. When we were collecting data for baseline data, we didn't use just desktop-based data, but we went on the ground to assess. Okay. We went into some of the hospitals. You realize that surgical teams are sidelines. Some of the doctors in the district hospital said that this is the first time a team had come into the hospital specifically to visit surgical teams and see what is going on in there.
Okay.
When you go to the district level and ask a surgeon what an NSOAP is, they don't know what it is.
Yes.
Another issue is about the community. For places where political situations are stable, members of parliament go to the community to campaign for votes. If the community is aware that our district hospital should have had a theater and a surgeon and a group of nurses who are specialized to handle surgical care, when someone goes to them and say, vote for me, they will let the person sign up to improving their theater. And so when the people on the grassroots start saying that we need surgical care here, until you bring us surgical care, until you bring us surgeons and anesthesiologists, we cannot vote for you. Then the politicians will begin to know that, yes, at the grassroots, they really know what universal health coverage is and they know what their rights are. So when the people at the local level start demanding, then politicians will be committed because they need votes from these people.
Yeah, most of the people started to laugh now, but we during this Ramadan, or our prayers is for our country to get back to this part, and to start the election, and communities start to bargain and to press on the politician on the service that they want and everything, and because we have long years and ages from this step, but hopefully we'll get there soon. Thank you for that answer. And based on your role in this Operation Smile and as an international NGO and your role in the Ministry of Health as well, now the question from a perspective of international organization, how do you think the role of international organization in supporting the NSOAP?
Thanks very much for your question.
Mentioning that the Operation Smile just joined after COVID, but in general, how the international organization like Operation Smile, G4 Alliance, and so on, how they could help?
First of all, the first step is for the international organizations ourselves to be communicating to each other to avoid duplication of efforts. Because I have worked in the government sector, I have worked with the Ghana Health Service for so many years before joining Operation Smile. And when we are there working, it's interesting when we get influx of organizations. So places where there are a lot of NGOs which are not talking to each other, one way or the other, they may not be getting things done because they will duplicate efforts. And people like to get resources double because the people are not talking to each other. So I'll say that the international organizations, whoever is somewhere and leads the process, should make sure that if Operation Smile is here, if Mercy Ships are here, they are communicating. knowing that Operation Smile has maybe donated an anesthesia machine to this particular hospital, another NGO does not donate the same thing to the same hospital. It goes to where it is mostly needed. Coming to that, international organization can support by providing technical support. For instance, we have had the experience of developing this NSOAP somewhere. If Sudan wants to develop, can we come with them and share our experiences, check with them from time to time? Are we an organization which have funding we could provide? Another key aspect, are we able to train surgeons? Are we able to train surgical teams? Are there scholarships for us to get people from Sudan to go and train and come and provide care? What form of agreement can we have with these people so that when they leave Sudan, they make sure they come back to provide the care, because that is where it is needed. So international organization can help in the form of training, providing infrastructure, leading in negotiations, and also advocacy, making evident the issues. But in key, the international organization needs to be communicating with each other so that there is coordination and efforts are not being duplicated.
Perfect. Thank you very much for this clear answer. Back to you, Elena. Do you have any point to add in the role of international organizations in supporting the NSOAPs?
I think Irene's again given an amazing kind of summary and real life practical experience. I think main points being the fact that they can provide funding, technical expertise, and again conduct essential baseline studies that help build the infrastructure. I like the point mentioned about advocacy. I think organizations like the G4 Alliance are very important. They play a very important role when it comes to advocacy because they help to increase donor investment into surgical care. And this brings the kind of visibility that we need when it comes to surgical backlog. So one thing this brings to mind is the fact that studies show that investing into surgical care is actually cost effective, which I think one of our, I think Al-Shahid can also speak a lot about, but the Lancet Commission estimated that around 350 billion invested in surgical care could yield an economic benefit of 12 trillion by 2030. And this is particularly important in low middle income countries because they avoid productivity losses. Mm-hmm. So you can imagine if you present this information to stakeholders, it can help to convince the governments and funders to prioritize NSOAP financing.
Okay.
Yes.
Great. Yeah, that's amazing. Thank you. Shahid, do you have any point to add in this part, or can push you to the...
I think everything that has been covered. So because as we said in the beginning, the adoption of successful implementation of national surgical plans cannot happen in isolation. So it requires the collaboration at multiple levels, including the strong partnerships with international organizations, the groups, and that could play a transformative role in these areas of providing technical and policy experts for effective planning, strengthening the workforce capacity through training and education, and support the infrastructures, the equipment needs to expand and surgical access, and advocate for funding and global recognition to ensure long-term sustainability as well. So by leveraging these partnerships, we can transform surgical care in Sudan, not just for today, but for the future generations as well.
Perfect. That is the perfect answer. So, taking you, Shahid, to a bit of a more technical question in terms of the international organization involvement in the surgical care. And most of the international organization works is kind of vertical approach into the health system. And can you please start by explaining what is the difference between vertical approach, horizontal approach, and how can we tailor our health system to accommodate this approach without getting affected?
Okay, thank you for this important question. So when we talk about strengthening the surgical care, we need to and we must understand how interventions are designed and delivered. There are two main approaches, the vertical approach and the horizontal approach. Each has advantages and challenges, and our goal should be to find the right balance to create the sustainable, resilient health system. So let's talk first about the vertical approach, which is focused, targeted interventions. The vertical approach is what most international NGOs use. It focuses on specific diseases or interventions operating as a standalone program. For example, an NGO like Operation Smile the Operation Smile, which comes in and organize a surgical mission to perform the cleft lip. This is a high impact but short-term intervention that provides immediate relief to patients. The advantage of this approach is that is specialized, efficient, and produce quick results. However, it can also be isolated from the broader health system. Once the mission ends, the local health care system might still struggle with the lack of trained professionals and surgical infrastructures or the long-term follow-up care for the patients. Going to the horizontal approach, which is strengthening the health systems, the horizontal approach, on the other hand, focuses on building long-term healthcare capacity instead of just addressing one condition. It strengthens the entire system, the hospitals, the surgical training, the anesthesia services, post-operative care, and the infrastructure, and the referral networks as well. So this means investing in workforce training, the hospital infrastructure, and the policy development, so that if we're talking about Sudan, for example, the Sudanese healthcare workers can deliver surgical care constantly and even without external support. This approach is sustainable and ensures the care is available for all the types of surgical needs, not just a single disease or intervention. However, as well, it takes a lot. It takes time and requires long-term investment from both the government and the partners. So we need to find the right balance between both of them. So there is then you speaking of the diagonal approach, and I believe that Enoch could talk about that more extensively, because Kings is famous for loving this approach, as I heard from Muhammad. So the diagonal approach, how do we tailor our health system to accommodate both approaches? We do not need to choose one over the other. And instead, we should take a diagonal approach, which is combining the strengths of both. So this means that running the vertical programs like the NGO surgical missions to address the urgent surgical needs while ensuring they contribute as well to the broader health system strengthening, and integrating these programs into the national strategy so that the knowledge and the equipment, the resources they bring, they benefit the system in the long run. Building local capacity alongside the vertical interventions. For example, an NGO provide like cataract surgery, should also invest in training Sudanese ophthalmologists and nurses to continue the work beyond the mission, and ensuring the government leadership as well. So the vertical programs align with the Sudan's NSOAP priorities rather than operating separately. In summary, the vertical approach is fast and targeted, while the horizontal approach builds long-term capacity. So I'm sorry if I'm talking a lot about Sudan, but because it's the panel mainly about how Sudan can benefit from that. So Sudan must adopt a diagonal approach, which is integrating the international NGOs' efforts into strong national surgical system. By doing this, we can as well deliver immediate impact while ensuring the sustainable locally led surgical care. And this is how we can move from short-term solution to lasting transformations in the future.
Perfect. Thank you for this great answer. Enoch, are you there? Or Enoch is not there. Perfect. So just a summary is the international organization, or most of the organization, as Shahid mentioned, they are a bit of specialized in one sector. They do like a standalone program intervention where we call vertical approach. And this approach has like positive and negative impact. The positive impact, as one of the questions here, is what is the urgent support needed for Sudan after war? Probably this could be solved by such an approach that is a very fast approach, has very fast outcome, easy to do. At the same time, will attract the healthcare workers, will drain the health system from the vertical approach, from the horizontal approach to the vertical approach. It's a bit challenging, but it will have a very fast outcome and has rapid impact probably. But if Enoch is there, Enoch, can you hear us? Where's Enoch? I've seen him. Yes, Enoch, you can unmute now.
Hello?
Yes, we can hear you.
Yes, I had logged out of my system. I don't know what happened for the past.
Yeah. We are sorry for this very inconvenient that's happening at the moment, but we have it under control for now. So, Enoch, the question is to you: what is the impact of the international organization intervention, or the organization intervention, the vertical approach, and how we can tailor our health system to benefit from such an approach, and what's the difference between the vertical and horizontal approach?
Okay, so I hope all you guys can hear me, but I can't. I'm not sure about the video. So
just a moment. Can you start your video now? Yes.
okay,
Perfect.
yeah. So so the thing about, I think our Shahid gave quite a great summary, but I just wanted to go to be very specific about the whole ploy on international organizations. So as we stand right now, about international organizations, we have to look into the political situation in every country, whichever the ones that have already done NSOAPs, and the ones that are that want to do it in the future. We have to look into their current political state, because that's, at the end of the day, the first word in this thing is national, means the government have to be very much involved in it. So if we have to look for other international organizations, from external international organizations to join in, the government has to be definitely involved in this, and the political state or the political ecosystem of that country has to be very much of a priority to look at. So, and as we stand right now, there's things like aid that have been banned to Africa and to specific countries. All these things tend to, they become like a conflict of interest when international organizations that are getting money or financing or aid from external sources, and suddenly they are not receiving this aid. It makes their delivery it makes it, they won't be able to deliver their promises well if that just suddenly happens. Mm-hmm. And then the other thing I wanted to talk about, I think Irene was mentioning about when we have a system where it's the people who are on the ground do not know what the national surgical plan is. So, when I was doing my research and looking into certain countries that don't have a national surgical plan, they have surgical ecosystem strengthening. So this, instead of, it's a vertical approach, but we are used to the vertical where it's top down. Like this NSOAP is more top down. It's coming from the government right down to the last person on the ground. But the surgical ecosystem strengthening has more of a bottom up approach, where we start with the local communities. So instead of having a national plan, we start with the local community. It can start with a neighborhood. Then you can go to a district. Then you can go to a province. Then to a state. Then ultimately it can grow into a national surgical plan. So that's what I understand and how I see the structuring of a vertical approach, or it all has to come to it's more national, it's more within the country. Now, when it comes to the horizontal approach, that's the one that's more, you have international bodies being involved at any level that they can be involved in. They can be involved on the national level. There can be aid where it's being provided on a national level, or where it's just someone like a private donor, someone, or a guy who grew up in a neighborhood and is suddenly successful and is donating. So
building from the infrastructure, I mean.
Sorry?
Building from the infrastructure, like targeting the health system, the pillars and the primary, secondary and the tertiary care, all of them together, supporting the whole system.
Exactly.
Yeah. That's really nice one. Thank you very much. I will now go to Elena, and my question to you is, what indicators would you recommend measuring the success of NSOAP and enhancing the surgical services? Elena, can you hear me? Are you able to unmute? Try now.
Thank you. Indicators of success. I would say again, indicators that the WHO and the Lancet Commission have aligned on. So access to timely surgery, surgical workforce density per. So that's the number of specialists per 100,000 people in the population. Again, surgical procedure volume, that's per 100,000 population. The availability of operating theatres, essential equipment, patient safety metrics, again, including the perioperative mortality and morbidity rates. And then the other aspect of it is financial risk protection to minimize expenses for people. So when we kind of use these metrics to evaluate an NSOAP's success, we can establish baseline targets, which is kind of, again, where a lot of NSOAPs start to do their work in countries. And then organizations like WHO can incorporate these metrics into their global monitoring systems. For example, the World Bank's SDG tracker uses specialist workforce density and surgical volume and financial risk protection to like appear in their databases. And then again, this helps us to kind of compare with our international partners. I think one thing to highlight though is the fact that it's difficult in some countries due to the fragmentation of healthcare systems or their information systems. So surgeries in like remote areas or smaller clinics, they might have underreporting of data, or death registries might be incomplete. And then also like financial hardship, sometimes it's hard to capture and survey data. These are all things that issues that I came across when I was also collecting my data. So when you are collecting baseline data, to make the surveys as extensive and as contextualized as possible to capture accurately the information that you need. I hope that answers your question.
Yeah, that's a very nice answer. and it is a very comprehensive. And we welcome as well Dr. Hamid from the Obstetric and Gynecology Sudanese Society. Thank you for joining us. We are almost 2 questions apart from opening the floor for the discussion and the further questions from the attendees. So, question to you, Shahid, as we started talking about the implementation, there is a question in the chat about the implementation. And the question is saying, what is the implementation challenges that could happen or could face the Sudan? I mean, amid the current situation and the current conflict. That's context related to Sudan. And in general, based on your previous research and based on your previous work at Shahid, before you answer the question from the chat, can you tell us what important findings you found regarding the NSOAP implementation in the low middle income countries? And what factor do we need to consider in our national surgical plan in Sudan to overcome these challenges?
Thank you for this insightful question, Mohammed. So I'll try to answer those questions while I'm talking through. So as we examine the implementation of the NSOAPs across Africa, we see common patterns, both challenges and successes that provide valuable lessons for Sudan. If you allow me to talk from my research and engagement in the surgical policy, I want to highlight the 5 findings that are essential for assessing and successfully implementing the NSOAPs. Firstly, the political commitment is the foundation. One of the most important findings is that the political will is non-negotiable. Countries that have successfully implemented NSOAPs, like Sierra Leone, as we've talked about this previously, had a strong government buy-in, integrating surgical care into their national health policies and budget without this, the NSOAPs remain just documents, not action plans. And for Sudan, we must ensure that high level of leadership supports the surgical system strengthening, advocating for this or for its inclusion in our national health strategy and funding priorities as well. Also, the sustainability financing or sustainable financing is one of the keys, or is the key itself. So the second critical factor is the sustainable financing. Many African countries struggle with underfunded NSOAPs, leading to delays for incomplete implementation. While international donors can provide the initial support, a long-term funding mechanism, whether through the government budget or the insurance schemes or public-private partnerships, is essential. And Sudan must ensure that the surgical care is prioritized in health financing discussions, and making sure that funding is predictable rather than crisis-driven. And the third part is the data-driven decision-making, which will lead to the impact. Like the successful NSOAPs rely on robust data collection and monitoring. In Rwanda, for example, surgical dashboards track progress in real time, helping the policymakers adjust the strategies based on performance. And for Sudan, we need a baseline data on surgical capacity, the workforce availability, and patient access. And this data must be used to set realistic targets, or track the progress, and ensure that the policies remain responsive to actual needs. The fourth factor is the human resources, as the health workforce development is a game changer here. One of the biggest challenges across Africa is the shortage of trained surgical providers, the anesthetists and nurses. Some countries have tackled that by expanding the training programs for health workers, encouraging task sharing, while non-physician providers handle some surgical procedures, and improving the retention policies to keep the trained professionals in underserved area. And talking about Sudan, we must invest in surgical education and training, ensuring that every region has access to competent professionals. Finally, The decentralization will improve the access. So we have learned that the centralized systems often fail to deliver equitable surgical care. Many African countries still have a centration of surgical services in urban centers, which is leaving the rural populations underserved. To improve the access in Sudan, we need to strengthen the district and the regional hospitals so the essential surgeries do not require long distance travel, and improve the referral network so that the rural patients reach the care efficiently, and also to ensure that the NSOAPs integrates primary healthcare so surgical conditions are identified before they become life-threatening as well. So for Sudan, these lessons are not just theoretical, they must guide our next step in NSOAP's development. If we implemented them effectively, we can build a resilient, equitable, and accessible surgical system that truly serves our people there.
Great, Shahid. Thank you very much for the comprehensive and extensive answer as usual. And my next question is, if you don't mind, just continue on to it. What is the role of the academic institute in improving the surgical care policy? And this question is to be taken by all of you. And it is our final question before we open the floor for the attendees to ask any question and to explore them.
Okay, thank you for that. So as we're trying now to advocate that the universities and the academic institutions in Sudan are not just places for teaching and research, they are a key drivers of health policy transformation. So when it comes to surgical care policy, their role is vital in areas like the evidence generation, workforce development, the policy advocacy, the innovation, and the capacity building. So if you let me to explain how these elements like shape stronger, more effective surgical system, the generating of evidence to inform the policy. So first and foremost, universities play like crucial role in research and data collection. Without evidence policy, policies are built on assumptions rather than facts. So the academic institutions conduct the burden of disease studies to assess the surgical needs, the cost effectiveness researches to show the policymakers that investing in surgical care saves lives and money as well, because they're interested in money and life both together. So health system evaluation also to identify the gaps in the infrastructure, the workforce, and the accessibility. So for Sudan, universities can help generating data to inform the NSOAP's development, ensuring the policies are not just theoretical, but tailored to real needs of our population. And the second part, or the second major role, is training the next generation of surgical leaders. So one of the major roles is educating and training the surgical providers, the nurses, the anesthetists. Without a strong surgical workforce, no policy will be effective. So the universities must expand the training programs for surgeons and the anesthetists, the pre-operative nurses, integrate the surgical policies and the global health into medical education to offer continuing professional development so the healthcare workers stay updated on the latest advancements. And by doing that, the universities will ensure that our health system has well-trained professionals who can drive the high-quality surgical care. Also, the policy advocacy and thought leaderships. So the academic institutions are uniquely positioned to bridge the gap between the research and the policy, so they can engage the governments to ensure the surgical care is included in the national health priorities, and to provide technical experts for the policymakers when drafting the NSOAPs, act as a neutral conference, like bringing together the ministries, the NGOs, the professional associations, to shape the evidence-based policies. Again, for Sudan, universities must play an active role in the NSOAP discussions, ensuring that the surgical care remains on the national health agenda.
Okay. So this is a really huge role for our universities to accommodate, but we'll listen to Helena and then Enoch and Irene in this point.
Thank you. I think I'll show you. I think to just go off the back of his point, the big role that universities can play, as already mentioned, is to help with the data collection, and that is one way they can really help shape surgical policies through just bringing this evidence to light, and as especially medics, when we publish work, we put it on journals like The Lancet, BMJ Global Health, and these are the type of platforms to help elevate the discussion. I think Irene did mention the fact that there's also a gap between when you do put out this research and information about it, the right people reading it, or it getting to the right people, which is why I think NSOAPs are important, because you can get these academic experts who put out this research on the NSOAP task force. They can help to build the relevant relationships between the relevant ministries, the Ministry of Health, Ministry of Finance, and they can also serve as kind of technical advisors to help shape the health policy. I think a good example to bring up is Rwanda's NSOAP. So their development was a collaboration between the Rwandan Surgical Society, the University of Rwanda, and their international academic partners. So you can see how important university and academics are here. I think from my personal experience, global health system strengthening, health system strengthening wasn't something I had heard about. It was something that was definitely in the background. It wasn't like a popular conversation. But in doing the Global Health Masters and being surrounded by doctors who bring this discussion to the forefront, which is why I'm so grateful for this meeting, actually, it demonstrates that there is a different way to look at how we carry out our work as medics, and that you can actually get involved in strengthening these systems where you see gaps when you're working. So I think discussions like this should also help to engage like the diaspora as well in different countries when they are going back home to their countries, or looking to do like other research and partner up with universities in different countries.
Amazing. Thank you very much, Elena, for the specific example of Rwanda and for elaborating on the need of diaspora support and the looking for the policy gap from a perspective of bureaucratics who are working in the hospital at the same time. Okay. Enoch, do you have any point to add in this question before we open the floor?
Yes, so thank you so much for the opportunity. I just want to add on and to highlight like what Al Shahid and Elena, they both said. Like, I mean, it's very important. Universities don't only play. I feel like it comes to they play like a serious role, because it's like the center of, that's where the discussion is heard through academia. I mean, right now we are having quite an academic conversation, and most of us here, if you see how we meet or how we conduct ourselves and all that, we met through university, through school, through all these academic institutions. So, and also talking about, like, I keep on coming back to the like financial constraints, and as Al Shahid said, I feel like academia kind of goes around, and because we can't have aid, as I said, and it's not also it's something also not as good to only depend on aid and financial support from somewhere else, but offering academia and universities kind of offer have some sort of indigenization, in which all the parties within that country or any plan within that comes from within, not from outside. So I kind of lost my train of thought, but like when it comes to academia can give something as like a platform in which we are sharing knowledge. So instead of not only having funding being transferred from point A to point B, we can also have a place where we are having knowledge being transferred from point A to point B. There are some countries that have done these NSOAPs, and there are some countries that have failed in doing it. But through these places, universities can have conferences and all that, where they can, have all these people come together and discuss on what best to and how best to move forward.
Great, thank you very much. Thank you all for these very informative answers. And I would now start by Professor Shadul. Thank you very much for joining us today and for supporting our discussions in most of these opening discussions, working towards supporting the Sudan health system and the improvement of Sudan surgical system in particular. Professor Shadul, can you tell us your insight regarding the national surgical plans and how the Sudan Medical Specialization Board could take the lead to be a very key, important role in this national surgical plans, specifically because our MD program has research, and most of the training program didn't have like research integrated into it. So having a research part in a national sector broad national program like the program run by the Sudan Medical Specialization Board is very important. How we could use these researches to build up and to inform our policy as well. Thank you very much, Professor Shadul.
Thank you, Mohammed. Thank you very much, and greeting to everybody on board, actually. And I'm also very grateful to the panelists, who really wonderfully covered this important topic. And however, I enjoyed very much the discussion and the experience of different people in different places, and especially in settings like Sudan. And I would like also to give some comments, actually, based on my experience with WHO, actually, in so many countries where I have been part of developing national policies in different countries, anyway.
Mm-hmm.
And then I will come to the Sudan Medical Specialization Board. So I'm grateful to especially Shahid actually has clearly mentioned the process of developing national surgical policies. And I won't go into that, but I will add some important points, which were also discussed by other colleagues, that the process of developing policies should be a sort of a very inclusive process. That's to say, involving, actually led by the government, involving the private sector, the community, the professional associations, academic institutes, professionals, international organizations, and all the stakeholders. So it has to be a very inclusive process. And at the same time, this will in fact lead to the point mentioned by my colleagues as well, the ownership, because it has to be owned by all of those who participated in it in order to ensure effective implementation of the policy. And it has to be based on real data collected from the country, actually, and setting priorities. And as mentioned by Shahid, that it has to be flexible and can be frequently updated. In case of Sudan, I believe the role of diaspora is really important. because there are so many Sudanese experts in such field in different places with different experiences that can really enrich the policy in itself. However, I believe that setting a national surgical policy standalone is not the appropriate way of doing it. It has to be part of a national health policy plan, which is also based on information and on consultation, especially between the community and the practitioner. It has to be part of the national health policy, not a standalone policy. And this will, of course, provide a lot of support, and those policies will augment each other, actually. It has to be a component of a national policy. Then the ownership by the stakeholders is really crucial. And the most important for me here is that it has to be a government priority. It has to be so. So it has to be led by the prime minister or whoever on top, and it should be the priority. And this will facilitate actually the advocacy, the allocation of resources, ensuring monitoring, ensuring its implementation. So these are steps, and some points I believe are very crucial in setting policies in general. As for the role of SMSP and universities as well, I believe it is very important. And in fact, in MSP now we have introduced a sort of policy setting and strategy setting as part of an MD for the health system, actually. And the most probably soon there will be a fellowship in this regard for those who did MD of community health or public health, actually. In addition, the SMSP is a platform where you have a very diverse experts of different specialties. We do have more than 63 specialized councils that we can benefit from different parts of the Sudan. So I believe the SMSP could and should be supporting the government and the Ministry of Health in order to develop appropriate policies for the country, especially at this stage where where we are facing a lot of issues, actually. So with this, I will say thank you to you, and thank you for all the speakers, and we look forward to listen to more views and ideas. Thank you very much.
Thank you very much, Professor Shadul. We are very blessed. We are very blessed to have you among us today. Thank you for all the support you provide throughout our discussions previously, and your insight and your experience throughout the previous sessions and the upcoming session, inshallah. Okay, so now if there is anyone else has any point to raise, and if Abrar is still there, and if you want to share your insight as well based on your experience, your work with Sudru and the other organization that you have been part of, and your work as well with the Sudan Medical Specialization Board. If you want to share any insight, please feel free to open your mic and say hi.
Thank you so much, Mohammed. Hi, can you hear me?
Are you still fasting? I cannot hear you well.
No, sorry, I have a flu. So, yeah, excuse me. Thank you so much, guys, for the education. This was really insightful and amazing. I'm not coming from a surgical background, maybe medicine and community medicine, but this was really insightful, and it brought a lot of ideas and future endeavors for what we can build for Sudan, hopefully, inshallah. So one of the points that has touched me, honestly, was the discussion around the involvement of the grassroots level within the policy implementation or policy development. Uh, this is really evident during our work in Sudan because we're considered to be a grassroots level organization and we have been closely working with international and national organizations and entities. And one of our activities were followed by the WHO and by the UN agencies is our work with the emergency response committees, which are they do represent the core of the grassroots organizations or response to the current crisis that is happening in Sudan. And they are bringing a lot of effort and a lot of enthusiasm beside a lot of points of action that could be included in any kind of policy brief, whether these policies were towards refining the health system or building maybe better sort of system, or uh, they can also go for the diversity, equity, and inclusion, as these are one of the main issues that we're facing and tackling right now with all the violent ethnic war that is happening in Sudan. So inclusion of this level into the conversation is really important because it brings a true reflection into what's happening in the ground, how does the implementation of such policies, for example, uh, is happening or is going to go, because we have seen a lot of gaps. We have seen a lot of challenges when it comes to the implementation of the policies and even at the level of the policy communication, not only the implementation. So if you look at the early steps, and that has brought to my mind that uh, if we can have like a fair model of inclusivity that could be brought to the table whenever we're developing a policy in whatever aspect, that would be amazing. So we can have like a model of um, inclusivity, then we can look at other aspects like localization, maybe if we're bringing a model from outside and so on. And also the second point is the integration or the effort that could that can happen within the academic institutions, as Prof. Shadul has mentioned. I think the integration of the non-clinical aspects with the clinical within the clinical specialties or clinical practice, it should be core. And if we can start that from an early stage, for example, things at the stage of the MBBS or let's say at the bachelor level and then furtherly into the higher level, that would be amazing because this is a gap that we have personally witnessed. I think Muhammad and the other colleagues we have experienced it that we usually sit at a table where we need to choose between the clinical and non-clinical, and whenever you choose one of those lines, then definitely you do exclude yourself from the other. It's very rare to find people who are actually combining both passions or both career lines together. And luckily, we have Dr. Sadun here with us because he is an example of having these two lines going together. Uh, he's non-pediatrician and also he's non-active and international community health expert, for example. So bringing the two aspects together, it usually brings the best out of any policy brief, for example, or any health system strengthening plan, because whenever you have your two fingers into two different areas, you get the whole sensation of what you're doing and how can you do it, and you get a true reflection between the theoretical part and the practical part alongside. And definitely, I would encourage having more conversations like this. And this was really insightful, and I think we can maybe we can extend the umbrella into other specialties as well. I know that this is your core and this is your focus, but in Figro we have an open umbrella so we can collaborate to include more and to bring more stakeholders. And maybe we can bring people from the grassroots level also, just to listen more to their stories or maybe to get the reflection of such efforts on from their side. And thank you so much for the opportunity. Thank you.
Thank you. Thank you, Abrar, for
Over to you, Muhammad.
thank you very much. Thank you, Abrar, for your insight and for affirming the opinion of Professor Shadul. And I think, yes, that's really like the goal is to have a proper health system that can fit all and can improve all the service, because the patient is need a comprehensive or complementary services. It's not just standalone surgery. So all of them are complementary. All the services are needed, and I think advocacy for all the services is important. And we are really happy and willing to go forward in advocating for this and supporting the ministry in this part. We have been. You still with us? Sorry. Professor Rashid was part of our call. If you are still there, can you please open your mic and say or mention your insight regarding the national surgical plans, obstetric and trauma, and from a perspective of a president of Sudan Medical Specialization Board as well? You have probably broader view as well, if you are there. I think he's not part of, he had the connection issue or something. So still the floor is open. If anyone has any point to raise, any comment, any question to ask. We almost finished everything and we are 9 minutes ahead of time, but please, if you have any point to raise, any comment, feel free to ask and to mention. Perfect. Then yeah, we call it a day, and thank you very much for your opinions, for your support, for reaching out, for attending today's session. And this is not the last, and there will be a sequence of similar discussion groups. We will continue into the specification of the surgical plans, where we discuss the workforce specifically. Then after that, we will discuss the infrastructure, how we will do the infrastructure, how we will manage the infrastructure, how we will assess the infrastructure, and the target for infrastructure. We will go then to the finance and to the rest of the pillars of the policy. And we'll keep discussing this in a day in like hierarchical models, and it will all be communicated through the social media. And we are just happy to engage with you all and to sit like such a sitting and to discuss these issues and to hear from you and to answer your concerns. Dr. Sadiq Suleiman, feel free to say whatever you want to say.
Hello.
Hello.
Hello. Can you
Yes.
hear me?
Yes, we can hear you.
Yeah, thank you, Dr. Muhammad, for giving me the chance. And many thanks to all speakers for the excellent discussion. I would also like to especially thank Professor Shadul for his insightful summary in such precise time. My name is Sadiq Suleiman. I'm a surgical registrar at Sudan Medical Specialization Board. Just I would like to share a comment, or it is rather might be a question regarding Sudan. I was involved as a data collector in 2019 regarding a study conducted by Public Health Institute to assess the health system governance. But I think till now, unfortunately, it was not published because the current situation in Sudan. So we often speak about the policies and the plans, but without strong governance and leadership, these plans may not translate it into action, as Professor Shador is already highlighted. So I wonder, in this context where governance is either weak or missing, and the political instability is a frequent issue, how can we practically build a resilient structure for leadership and to survive beyond the political change? So I think it is just rather than a question, it might be a comment. So that is it. Thank you once again for this chance.
Thank you very much. Thank you very much. This is a very important comment, and specifically, as you mentioned, in our situation, the current situation in the country is very crucial to context and to consider the governance and the leadership and the buy-in first. Then after we have a buy-in from the government, all the NGOs, all the volunteers, all the diaspora should support the government to implement their peace plan. So our role is now just to buy in the government, to hand the government this, and to support the government through our networks, through our connections, through our international links, to help the government implement these plans, implement these services, and plan the national plans and so on. So it is kind of start of advocacy to get everyone on board and to start push this together to help our country stand up again. Thank you very much, Asadik, for your comment. It's really nice comment.
Thank you.
Thank you. Perfect. Thank you very much. We'll meet in the upcoming discussion. Thank you.